So here we are. This is Ian Hart, co-creator of Back Pain Relief for Life, and I'm here with Dr. Stuart McGill. He is the Professor of Spine Mechanics at the University of Waterloo in Ontario, Canada, and he's one of the most sought-after experts and consultants and author for back pain relief performance, and his books and DVDs can be found at backfitpro.com. And welcome and thank you, Dr. McGill.
Yeah, thank you, Ian.
All right, so there's a few questions I want to ask, and a lot of these questions are pertaining to everyday questions I get from clients and also fitness professionals. But I think the first thing is, why is back pain such a monstrous epidemic nowadays? And is the spine more vulnerable today than, say, 40 years ago?
Starting with the easy questions first.
Exactly.
I don't know the answer to that, Ian.
Okay.
However, if we go back even into the ancient Roman scrolls and Egyptian art, we see pictures of people expressing their back pain and trying different mechanical postures and movements to deal with it. So it's not something new, that's for sure. However, I think with the advent of the personal computer and how people's jobs have changed so radically, I know even my role as a professor has changed radically over the years, where virtually everything I do from an administrative point of view through to teaching is done via computer.
Right.
And we're all sitting much more and longer. And some of us elect to engage in fitness programs because of this general sedentary lifestyle. And we go very hard in that 1 hour training session, and then for the other 23 hours we're quite sedentary. And that regimen in of itself is problematic.
So that sitting down all day could potentially lead to people's backs getting worse throughout their life as they sit down at desks.
Yeah, there's no question. Yep, sitting for a long period of time is quite stressful for the back for quite a number of reasons.
Okay, and you also brought up about people engaging in an exercise program. Now, a lot of people are scared when they have back pain to engage in exercise, and sometimes they just don't do anything because of the pain in their back. When is it appropriate to exercise? Which exercises should, and obviously this can be a complicated question, but in general, which exercises should people stay away from, and what exercises will help strengthen the lower back, core, etc.?
Okay. I'm just going to clarify a few things there, because you started the question out talking or referring to back pain, which is a generic malady, shall we say.
Right.
And here's the thing. There is no good instruction for someone with back pain on what they should do and what they shouldn't do. It's very much dependent on the person. So
right.
If we go back to more general principles, we could say avoid the mechanical cause of your back pain. So people, when they think about it, in terms of motions, postures, and loads, they should be able to identify motions, postures, and loads that exacerbate or make their pain worse. They should also be able to identify motions, postures, and loads that are tolerable. So the exercises that they should do are the ones that are tolerable but address their deficits, and the ones they should avoid are the ones that make their pain worse. So that's the answer from a generic point of view. But if we're going to get specific, we would have to use examples of specific categories of back pain. So let's take a 30-year-old person who works in an office but they're quite keen to maintain their fitness and appearance and that sort of thing. So once a day they go to the gym and have a good training session. It probably bothers them that the slob who sits beside them at work, who never trains or works out, never complains about back pain.
Right.
And here's the funny paradox that is quite unique to backs. Pain in that 30-year-old office worker is most probably discogenic pain from the disc. Pains in other periods of the life cycle come from different tissues and different mechanisms, but that would be a good generalism to characterize that type of person. The person who never trains or works out never builds up any cumulative trauma, or more specifically delamination in the discs of their back. So they remain pain-free. But then again, their work capacity is very low. They couldn't go out and go for a run or a lifting session or whatever. They just couldn't take it. However, the person who does train, and they train probably with too much of a flexion bias, too many sit-ups and too many, we could say, full motion crunches, etc., maybe too much stretching, they start the delamination process in their discs, so that when they go back to work and sit for a few hours, that becomes a very painful enterprise. If they didn't work out, they would probably have less pain. So that's the craziness of all of this. But I'm certainly not advocating don't train. Quite the opposite. It's the way that you train so that you don't build up cumulative stress in any one area of the body. And keeping that in balance is one of the key principles to reducing not only back pain, but pain throughout your body.
Great. That actually leads to my next question, which is, why are crunches and why is spinal flexion, you might have answered this, but why is spinal flexion or repeated spinal flexion deleterious to the spine, and what should be opposing the spinal flexion? Or you said if too much stress on one specific spot could cause pain, what should someone do as opposed to crunches?
Yeah.
Or
I understand your question. I'm just going to define for your listenership what flexion is versus flexion effort or moment. Flexion movement is what your spine goes through if you do repeated sit-ups. You bend the spine forward over and over and over again. That is different from flexion challenge or flexion torque. If you're familiar with doing, say, a push-up or a stir-the-pot kind of exercise, that is still very challenging to the abdominal muscles, and yet no flexion movement takes place. So that's what people don't recognize is there's a difference between using your abdominals and creating flexion effort versus flexion motion. Flexion motion with compressive load is an injury mechanism. We've proved this over and over again, that if you keep bending the spine under compressive load over and over again, you will work the nucleus, the center gel of the disc, through delaminations that will slowly accumulate. Now, I don't want to get ahead of myself, but make a note for later that that's person-specific in of itself. Heredity does make a difference there. But nonetheless, that combination of flexion motion with compressive load from muscle activity will slowly lead to back pain versus if that same person was to avoid repeated curl-ups where they're bending the spine or repeated sit-ups and replace those with exercises like the stir-the-pot, which is basically a push-up posture where the elbows are placed on a big gym ball and they swirl their arms around. And stir-the-pot is a good name because that's what it looks like. That is a terrific abdominal challenge, but the spine isn't actually bending, and that does several things. Now the tolerable training volume in that particular individual grows. If you keep doing flexion motion, using the sit-up example, the person will actually wear or work on the discs of their back more than the actual muscle. So they're wearing out the joints before they wear out the muscle. Well, your objective is the opposite. You want to spare the joints and really train the muscle underneath. So you can see how exercises like, say, doing a push-up and a walk-out with the arms, or pushing exercises, or stir the pot, are all very abdominal muscle intensive, and yet they spare the joints underneath, therefore increasing the tolerable volume. So you get more development of athleticism and less pain. So do you see it's back pain type specific to answer that question.
Okay, perfect. I think that got the point across. Now, when is bed rest appropriate, if ever, for back pain? We hear it all the time. I still hear it to this day. Doctors saying just rest, don't do anything for your back. When is it appropriate for bed rest?
Yeah, well, that's an excellent question, because like most of my answers, there's a time and a place. And what I mean by that is those people who are listening to this who've experienced the real sharp stabbing back pain and they're about 30 years old, that's discogenic back pain. When the person gets locked up and it's just absolute murder with these, they will describe the sensation like knives going into their backs. Probably laying down in bed rest for half a day is advisable. However, the trick is to, as you are laying, trying to find a position that resolves this very acute sharp attack. So if it is of the type, say the person was bending over and tying their shoe, or they sneezed and that threw their back out, that is a flexion-based disc bulge, and it's trapping a nerve root, creating that real knife pain. When they're laying in bed, if they could lay on their tummy and work into a position where they could put one fist under their chin while they're laying on their tummy, they would find that they could then stand up, work themselves up onto their hands and knees, sidestep out of the bed, get to an upright position, and they'd find that would enable them to really shorten the duration of bed rest so they could get moving once again. And the funny thing is, disc bulges that create those very sharp acute attacks can be worked back into the center of the disc, reducing the bulge, if the right combination of positions and loads are generated in the back.
Okay. And
Ian, may I just say one more thing to answer your question?
Sure.
I think the other part, when docs say, "Oh, just try bed rest for back pain," that has been shown to not work well at all. That's we're not talking about the stabbing sharp attacks now. That's just someone who is just getting worn out from their back pain, so their solution is to simply go to bed, and that's just a spiral.
Perfect. Thanks for clarifying that. Now, there's a ton of surgery going on, too, with back pain. And I always feel, my personal belief, that it should be the last resort, but it seems like sometimes it's not the last resort. When do you find that it's appropriate for surgery as a relief or as to help eliminate back pain?
Well, if you're sticking with the back pain definition, I would say never. Absolutely never. Now, if I can expand that idea of back pain and say, well, was this subsequent to trauma? Did they fracture their spine in a car accident or something like that? Then is a case to justify spine surgery. Or if they have unrelenting pain down their legs. So it's no longer really back pain, but it's radiating pain. Clearly a nerve root is trapped. All conservative approaches to pain management have been tried and failed. They've lost bowel and bladder control. These are all markers to justify a surgical consult. However, if they've been given the diagnosis of degenerative disc disease and they have more than one level in their back that's involved, so they've got flattened discs at more than one level, back pain is surgery is a very, very poor choice. They're just rolling the dice now. The chance that a surgeon will be able to go in and cut out their pain when they have multiple levels involved and several sources has been shown to be, well, the surgical disaster. And these are the kinds of patients that I have to deal with.
Right.
But you know what's so interesting about this, Ian, is that statistically, the studies show that those who go in for back surgery for nondescript back pain, while they roll the dice, and some will become very incapacitated afterwards, and some will be quite improved. But after 10 years, everybody's even up. So if they let nature take its course, and better yet, if they understood the cause of their pain and dealt with it through people who understood their movement patterns, addressed the deficits to put their body back into balance and dealt with their back pain that way, generally speaking, they'll do quite well. When I hear, oh, I tried all this conservative therapy, physical therapy, I saw my trainer, etc., and it didn't get better. In fact, it got worse. I would have to say you saw the wrong physical therapist and the wrong trainer. But if you saw the right ones who understood the source of your pain, they could have designed a better program for you.
Right.
Even if they didn't do anything, they're even up after 10 years.
Right. Good.
You know, back pain has a natural history to it. You don't hear of 80-year-olds, as a rule, complaining about back pain. You do occasionally, but generally they complain about other things. But when you talk to them, they'll say, oh, yeah, I had a bad back when I was 30, 40, and 50, but I grew out of it.
Now, that's a good point that you brought up, because in reading Dr. Sorno's book, Healing Back Pain, he talks about the psychosomatic issues with it, and you touch on this in your book, Low Back Disorders. How much of it has to do with emotional factors? I think he was stating that, you know, between 30 and 60, there's a lot of stress and emotional issues. How much of it is psychosomatic? How much is physical?
Well, there's no question that a positive attitude, and that's what Dr. Sarno really promotes. A positive attitude will help. But I will say it absolutely is not the cure. And if the person's pain is real and it's coming from damaged tissue, from repeatedly poor movement patterns or bad lifting patterns or whatever it happens to be, no amount of positive attitude will help that individual. Now let me give you the opposite side of that argument. I've had many patients like this, but I'll give you the example of this one to illustrate. This fellow was a very solid citizen in the community. He wasn't faking his back pain. His doctors, and he saw several, told him, we don't understand your pain. The pain must be in your head. And he was eventually sent to a pain clinic, and their solution was to load him up on narcotics, Demerol and the like, and they had him write down his pain. Oh, is your pain a 6, a 2, an 8? So he could document his pain throughout the day, which was absolutely the wrong thing to do, because he focused on his pain.
Right.
I saw him, and he said, Doc, I hear you're different, but they tell me the pain is in my head, but it can't be. It's too real. However, if it is in my head, I must be crazy and I don't deserve to live. And if you can't take my pain away, I'm going to put a bullet in my head. This is a real situation. I've seen them being driven to suicide, being told that the pain is in their head, and all they have to do is take a psychosomatic or a psychophysical kind of approach. The fact of the matter is, when that person is shown motions, postures, and loads and how to put their body back into balance, and their pain subsides, they're able to have a good night's sleep. They're able to eat well. They're able to tolerate good training activity once again. All of these things will strengthen them again, not only their body, but their mind. A good night's sleep won't rob them of the softness that they get mentally. All of a sudden, they'll be able to handle the rigors and challenges of daily life. But it started by taking their pain away, not by telling them that they have to get used to it.
Now, that leads to my next question, actually. When you brought up the medication point, a lot of people are going to doctors and they're getting, I think, Celebrex, and there's a few others out there. Can you just give me your thoughts on pain medication for back pain, and is that ever necessary, and what's that really doing to the body?
Well, I'm really not qualified to talk about meds, but I can certainly give you my own opinions on them.
Okay.
Celebrex may help some arthritic conditions. There's no question about that. But for the more common causes of back pain, again, there are better, shall we say, physical methods.
Right.
And our job is to get the people off their meds.
Okay. Fair enough. That sounds good.
I can think of the example, you didn't mention methocarbamol, which is a muscle relaxant. And so many docs give muscle relaxants for back pain. The best muscle relaxant is posture change. If a person is bent over and in a flexion antalgia because of their back pain, no amount of muscle relaxant will shut the muscle off. But if you can get them to change their posture, they can shut their muscle off, and they'll say, oh, you're absolutely magical. You just took my muscle cramps away. That was through changing their posture so they didn't have to support their back against the loads of gravity.
That's a great point. Now my next question is another question that I think that the general population is maybe misled, or they have a bad understanding of how everything works. When they go to get an MRI and they're given feedback on their MRI, would you say that's a good indication of their current situation of the spine, the discs, the nerves, etc.? And what can an MRI really give you in terms of feedback of where your spine health is?
Okay. Well, I think there's two questions in there. Generally speaking, most people would be better off without an MRI, and some people would say that's irresponsible. However, the picture of the anatomy very rarely helps. You will have some docs who say, well, I can't see anything on the MRI, therefore your pain is not real, or I don't understand it, and it must be in your head, go away. Or they will look at the next MRI, and it looks absolutely awful, all kinds of things that could be possible pain candidates, and yet the person doesn't have much pain. But here's the concept that would help people understand. As you age, there's no question the discs will slowly dry out, lose water content, and flatten. Right. Say a person did damage one of their discs or their vertebra with, say they had an end plate fracture during a lifting injury. So that joint is now flattened. Over the next 10 years, they will have a load intolerance. When they have poor form when they lift, they'll increase their back pain. When they sit too much, they'll increase their back pain, etc. But after about 10 years, their pain will start to go away. And yet, the MRI through this whole 10-year period has looked worse and worse and worse. First, it shows a flat disc. Then it shows sclerotic bone growth. Then it shows arthritic spurs are starting to grow around that unstable segment. Then the facets start to atrophy and glow on the MRI, etc., etc., etc. So after 10 years, it's a terrible-looking MRI, and yet the term we use is the pain has burned out. after 10 years, the arthritis has fused up the joint naturally. There's no more motion left in the joint. The bone spurs have grown over the whole thing. So as I said, the bad news is that the MRI looks awful, but the joint is now stabilized. Guess what happened to their pain? It's all gone. So that's why the MRI doesn't correlate with the pain. Now, if you're going to have surgery, the surgeon needs to know what he's going to cut out or alter to try and change the pain generator. That's when the MRI is used. So once the person has been identified as a really good risk and a high probability of a favorable surgical outcome, then have the MRI to guide the surgeon what he may have to go around, what he may have to really alter. But again, his risk versus reward, the reward increases when there's just one thing that the surgeon knows that he can go in and alter. But if there's more than one, you're now really rolling the dice and just hoping that he gets the one that's the major pain cause. But anyway, that may help people interpret their MRIs. And one other thing that I've written a lot about in my books, and I chide the radiological community for, is the radiologists never see the patient. So when they see the MRs, they look at some peculiarities and just state what the peculiarities are. But who's the person that makes the links between the MRI findings and the actual patient? That's
right.
It's not the radiologist, because they never see the patient. So there's a missing link in the whole medical process to really obtain the information. So I ask every patient who I see, they have to bring their full set of medical images. I never look at the images until I examine them. And then from the results of my exam, where I've already identified motions, postures, and loads and tissues that are all pain generator candidates, then I look at the MRI and say, well, that makes sense. There's edema in that bone. That's a bone bruise. That is accounting for why they can't tolerate compression. Or they might have a shear intolerance, and I'll look and say, there is an open, very dynamic shear instability of the spine. But this is all done afterwards. But that's not typical medical practice at all.
Okay. All right. Thanks for clarifying that. Now, the next question
I have to tell you, you're really wise in asking these questions. You're hitting exactly the right issues. You've been around this before.
Yeah, I mean, I really appreciate you clarifying these things, because there's so many myths out there that, and everybody's confused about back pain, and doctors are more confused sometimes than the patient, and I wanted to make sure that you touched on those things, because you're the expert and you know and you've seen so much and researched so much that it's hard to defute what you're saying, right?
My wife would argue with you. She still thinks I'm an idiot, but in any case.
That's all right, though. That's always going to be that way.
Yeah, you know what? You're right.
Same here. Same issues here. Now, now, I had a consultation today, and I see this often. The lady said, I had a car accident 6 months ago, or 6 months previously, and then 6 months later I had sciatica, and she somehow linked it with the previous accident 6 months before. How much does trauma play into back pain, and how much is it genetics, and where are the statistics, and what does the research say when it comes to these issues?
Okay, well, you will not find a single good source out of the research literature to answer that question. The only way you can answer that is to spend a good number of years and having a lot of applied and practical experience just with dealing people, and see who does well with certain approaches and who was traumatized and who wasn't. and doing the science yourself so that you really understand the various links that exist. So it's up to someone who has a lot of experience, I think, to put it all together to answer that question. You will not find an answer in a single book, for example.
Okay.
However, let's start the genetics component of your question. Let me give you an example. Not everybody is designed to play golf. Consider a rod, which will be the spine, and you're going to twist that rod. Now, if you had a thick rod or a thick tree trunk and tried to twist it, you would shatter it. But if you had a thin rod or a narrow, very thin tree, you could twist it and it wouldn't break. And the reason is you wouldn't create high stress. So a thick rod creates a lot more stress than a thin rod for the same amount of bend, shall we say, or twist.
Right.
So if a person has a very slender spine, and I see this in a lot of the professional golfers, they may look like bigger people on the outside, but when you look at their x-rays and their MRs and whatnot, generally speaking, they have a slender spine and open facet joints and whatnot. So in other words, genetics played a role in determining what mechanical variables their spine will tolerate. Now, let's take that same golfer's spine and put them in the NFL at middle linebacker. They will not survive because the very features that allow a spine to be good at golf are the antithesis of those that would allow you to survive playing middle linebacker. Those people need big, thick spines with Limacon-shaped discs that can bear the compressive stresses of getting banged around in the NFL. But don't ask those guys to play golf. So you see, if golf was just about being strong, the middle linebackers would be playing on the PGA Tour. But you can't find those guys who can hit a golf ball very far.
Right.
You see the difference? So this is why genetics predisposes us all as to what activities build us up versus which activities tear us down. And that would be different between individuals. But when you've been looking at it for 30 years, you start to get an idea of why and I'm rather unique in my career. If you talk to the average family doc and say, well, how many PGA Tours or how many Olympic medal sprinters have you looked at, or rowers or whatever, they'll probably have to answer and say none. But I'm a bit lucky in that I see a number of these different people, and when you see enough of them, you start to see patterns emerge, and those patterns tell the story in terms of genetics.
Right. Okay. Now, on to a big topic for strength and conditioning people, and also people, just the general population, is deadlifts. Many people in the general population don't, or they have a fear of their back, let's say. So when they do a deadlift and they feel those muscles working, they think they feel their back, they think it's pain. Now, what type of deadlifts, or when is a deadlift appropriate for just a general population?
So these are people who've never had back pain?
People
or have
with
a back pain history.
Yeah, back pain history.
Well, the first thing I have to do is determine what they tolerate. And if they tolerate compressive load on their back, then I'll say, all right, well, you're a candidate to do higher load exercises, which is a deadlift. The next investigation I would perform is what type of hips do they have? Do they have shallow hip sockets or acetabulums, or are they deep? Now, if they're deep, chances are they should not be deadlifting from the floor. They should be picking up with a dead weight that's been elevated a little bit on some blocks.
Right.
So you see, once again, it depends on what the shape of their hips are as to what style of deadlift I would consider. I'd then manipulate some of the stylistic features of a deadlift to try and shore up whatever weaknesses it was that we detected. One example of that would be as the person is setting up for the pull. So they've gone into the deadlift, they've hip hinged, they have a neutral spine. Now the trick would be to really stiffen their whole spine. So they'll grab the bar with a double overhand hand grip, not a reverse hand grip.
Okay.
And the first thing they do is, as they're grabbing the bar quite robustly, they try and twist the bar by engaging the lats. And what that does, it stiffens their entire back all the way down to the sacrum. So by bending the bar in external rotation, that stiffens the whole back. Now, if you set up in what's called the lifter's wedge, so a nice stiffened wedge, you've grabbed the bar, you've bent the bar, you've stiffened your hips, you're spreading the floor, all of these pre-stiffening conditions. Then simply squeezing the bar harder picks it up off the ground. Do you follow?
Gotcha. Yes.
Yeah. Now,
Yep.
do not lift with your back at that point. Instead, slide the bar up, and I don't know whether it's below the knee at this point or above. It depends on, again, how you set up that individual person. But as they squeeze and externally rotate and then grip into the ground with their feet, externally rotate and spread the floor through the hips, they don't lift with their back. The instruction is simply pull your hips through. And that acts as a cam about the hips, so there's no possibility of any shear loads working into the back, etc. And as long as they tolerate compression, you should have a very successful deadlift for that person with a history of pain. The last, can I say one more thing about this whole issue, Ian?
Sure.
And that is, we never did ask the question, was the deadlift the very best tool for addressing what you were trying to achieve? In other words, could we have, deadlifting generally uses up a lot of capacity out of the back. If you have a good deadlifting session, generally there's not much capacity to do too much more.
Right.
However, if we didn't use it all up on deadlifts and we took a heavy 2-inch manila rope or a 1 3/4-inch manila shipping rope, and you simply gripped into the ground, put a big weight on the end of that rope, say 30 meters away or 30 yards away for you Americans, and then pull that rope in hand over hand, you're going to develop a balance between grip strength, back strength, hip strength, hamstring strength, etc.
Right.
And then you might say, okay, well now I'm getting some good endurance and really balancing the posterior chain. Or maybe you might want to do some sled dragging exercises that aren't just quite so intensive in terms of using up that deadlift capacity. So that's the second part of the question. Not only there are all sorts of tricks that we can use to make the deadlift not only more tolerable, but a more an exercise developing of athletic prowess. But also ask the question, is the deadlift the only tool in our toolbox that we can use, or is there something better to get the job done?
Okay, that makes 100% sense. Now, as we come to the end of the interview, I'd like to ask you, someone suffering from back pain, what are 3 action steps you would tell them to take to get them on the journey for relief?
Find out the cause of your pain, and if someone can guide you, it will reveal itself. What I mean by that is pay attention as to what activities cause pain, and then try and figure out what motions, what postures, what loads, what repetitions, what time of the day, what features cause the pain, and isolate them, and then stop doing it. So that's number one. Number 2 would be to have an assessment from a competent individual who understands how not only the back works, but the entire body linkage. because sometimes stiff hips is the real culprit in this particular person. Or maybe it's a bad knee that every time they have to work around that knee, and that's propagating through the linkage into the hips and the back and the shoulders. Maybe when they put a bar on their back, they don't have enough shoulder or thoracic spine mobility, so that now manifests as a bending stress in their low back. So that assessment is critical. So now you know what the cause is, and now you know what to not do. That's huge. Right. Too many people just jump in right away. Well, here are your corrective exercises, and here's your workout problem.
Right.
But they forgot those first two steps to really eliminate the cause. Now, the third element, which most people get, is a progressive training program that stays within the person's tolerance and really addresses their deficits. Now it has a chance to work because they've eliminated, it's like picking the scab. They've stopped picking the scab, allowing that to heal now, and address the deficits, as I said, with this progressive program. So I don't know if that's 3. It sort of is.
Yeah, that works perfectly. And the next question, the final question that I was going to ask you is, with all that said, those 3 steps, what could someone do right now? And I know this is going to be specific to each individual, but is there anything that someone could do right now that's going to provide them some relief, or any exercise or something that they could do right this instant?
Well, I'm going to be smart and say read my books.
All right.
But to be a bit more directive than that, again, Ian, it depends on what's causing the pain. Again, for that posterior disc bulge, the discogenic 30-year-old, simply laying on their tummy and placing their hands flat to the ground, but stacking them underneath their chin, and just lay like that for 5 minutes and see if that helps or hurts. It's going to do one of the two.
Right.
And does that take you in a direction that is helping your back, or does it take you into a direction that's making you worse? But there's a nice little test right away to see if that's going to help you, and it's something you can do right now to change the pain that you're experiencing. Okay,
great. Now, as we close here, I wanted to ask, is there any presentations that you're going to be featured in, or anything that you can kind of let us know where you're going to be, and if someone wants to see you or see where you're presenting?
Well, there is. If folks were to go to the BackFit Pro website, so that's www.backfitpro.com, there's a little tab, I think you call those, at the top of the website that says Courses and Clinics. And if you click on that, you'll see the public ones that people can sign up to go to. I do a number of private ones, obviously, that are closed to the public. But the public ones are listed on that website. There's the next 2 years, I think, that are listed there. But they're mostly in the U.S. There's a few in Canada and a few in Europe. I think for 2015, there's going to be a couple in Asia and Australia and whatnot.
I really appreciate you doing this. And again, everybody can go to backfitpro.com, correct?
Yes.
And they can purchase books, DVDs, and then also see presentations that you're at?
Yes.
Okay. All right. And is there any last thing you would like to tell the people who are suffering with back pain, or anything you'd like to add to this?
I think I probably talked enough, Ian. They're fed up of me.
All right, Dr. McGill. I appreciate it, and I will talk to you soon and send you the link to this interview.
You're welcome. Thank you very much, Ian.
Have a great night.
Yeah, good luck to you.
Bye.
Bye-bye.